final venture presenting today. Thank you so much, Dr. Vaishon, for your patience waiting to be the last venture presenting here today. Seems like you've got your slides going up just fine. You can take yourself off mute. That'd be great. Oatmeal Health is an AI-enabled cancer screening as a service for underrepresented patients of FQHCs and health plans. Dr. Vaishon, you can take it from here.
Excellent. Thank you. So my name's Ty, and I'm a radiologist by training. And if I didn't have this funky screen here, you'd see my giant radiology computer behind me. I've been looking for lung cancer for about a decade, and we've been chatting with a lot of clinics to figure out a better way to improve cancer screening. In addition to looking at my giant radiology screen, I've been pretty involved in the AI space. I helped many of the companies build their algorithms. And so with my background in clinical radiology and my technical background, it was a good time to try and figure out a better way to address lung cancer screening. We're in the middle of a raise right now, a raise of 1.2, and we have multiple letters of intent with clinics and primarily federally qualified health centers. So we're starting with lung for a couple of reasons. More people die from lung cancer than the next three combined. But more close to my clinical workflow is the screening system is just terrible for lung cancer screening. It's been around for 10 years, reimbursable for 10 years, CMS and private insurers, and less than 5% of eligible Americans were getting screened. 2 years ago, we changed the criteria, tripling the number of eligible Americans. So we have a terrible system, and then we dumped more people into it. And so from an entrepreneurial standpoint, this felt like a really nice problem to solve. And so to specifically address screening, I feel like equity is built into it. And so we reached out to the federally qualified health centers. There is a standard of quality for FQHCs, and it's similar to HEDIS, and it's called UDS. Clinics have to report these metrics. And so the metrics right now that are mandatory reported are breast, colorectal, and cervical. And the arrows to the right show that the clinics that we are tending to talk to are struggling to meet these metrics. Lung is going to join as the fourth one per NCQA in about 18 months. And so to add more insult to injury, like how can we ask clinics to do more? And so to further elaborate on the problem, we have plenty of ribbons. We have plenty of months. We don't need ribbons, months. What if we could safely and effectively just take cancer screening off the plate of the clinic? And so that's what we want to do. And with my background in tech, I feel like there's a couple of different ways we can do this. And the first one is who's even eligible for lung cancer screening? We need to figure out who's got a 20-pack-year smoking history. And that's not typically searchable in EHRs, at least the ones that we're chatting with. Once we figure out who to screen, we'll facilitate the screening. And then we can do some cool things with AI on the images that are collected. And then we want to work on some educational material, and we can leverage some generative AI to do that too. So this is how we envision our patients walking through this when we collaborate with a federally qualified health center. We scrub the EHR and figure out the list of who's eligible. We contact them to make sure that they're reimbursable by US, PSTF, and CMS guidelines. We help make sure they get to the scanner at the right time, at the right place. And then we also compare the AI read that we're going to do with the radiologist read. And then we're going to make sure patients come back every year. When I turn on my radiology computer and I do a screening, I must see the prior year's exam. I have to. That's the only way I can see if something's changed. And so we're going to encourage patients to come back year after year. Obviously, this is great for everybody. The clinics have their quality metrics. The health plans get to save money because finding cancer earlier is cheaper. I'm a medical doctor. I want patients to do well, and this is great for them. And then our investors can realize returns as we grow. Very high level, there are multiple CPT codes that can be billed on the tobacco cessation and the shared decision-making visit. That is just, I think, outside the scope of what the FQHCs are tending to be able to do. And so we have a team of billing advisors that are going to help us bill this properly. And this generates revenue for the clinic. And then we ask for a per member per year fee. So this is not even a sell. This is a partnership, which has worked really well for us because the top of our funnel is bursting. Like we can't even take any more clinics. They say, you're going to help us do the cancer screening. What are you waiting for? Well, we're waiting for funding. So we're in the middle of our $1.2 million raise to build the tech that I said to make the list of finding eligible patients. So Jonathan and I have been working on this for about 14 months. We have chatted with many federally qualified health centers and the state primary care associations and the federal National Association of Health Centers. Like, we've been chatting with a lot of people to make sure that we have a great solution. We have a great tech team to help us build it out. I'd love to answer some questions, and please connect with me if you like.
Thank you so much, Ty. Fantastic presentation and great work that y'all are doing. Really excited for your next steps. And folks, please connect with their team through the QR code provided here. First up from the judges is Meg Hendry, Managing Director at KPMG. Meg, thanks a lot for joining us again.
Yeah, absolutely. It's so exciting, and love to see anything come off the FQHC plate. I do have a question about patient engagement. So obviously part of the challenge is to identify these folks. It sounds like you've got some innovative, ways to scrub the data to find them. But have you given some thought to how you actually engage with patients, often from communities who are hesitant to engage in this kind of screening? How have you thought of tackling that challenge to sort of get them all the way through the funnel?
For sure. And we've just been listening to our customers, and we go zip code by zip code, talking to every FQ. And if they like Epic Messenger, we're going to use that. If they like Care Messenger, we're going to use that. If they like text or whatever they like, and they have strong feelings, and we didn't know that they would. And so, and they even have a pretty reasonable response metric. And so we'll defer to the clinic. And this is a great time to mention that this is cancer screening for the clinic, powered by Oatmeal. We don't want to get in the middle of that relationship because we know it's critical.
Great, thank you.
Thanks a lot, Meg. David, can you jump in?
Sure. Ty, thanks for the presentation. Very interesting. I have sort of a two-part question. Number one, as far as branding goes, within an FQHC, will the patient or the family see Oatmeal Health, or will this be just part of the screening process, the onboarding, the admissions of the patient into the clinic?
We're going to, again, defer to the clinics on this. If they truly want to make it white label and no one sees the Oatmeal name, they probably won't. However, I think we add a little bit of elevated quality when it shows that the clinic is being supported by, the newest kind of cool thing. And so in our contracts, it's specifically worded that the clinic has the final say. But I think that there's benefit to us with our own marketing that we're going to do. That patient can say, I want that. And so I think, but it will defer to the clinic to make sure that they are comfortable with it.
And just a quick follow-up, if I can. So then the individuals inside the clinic that are meeting with the patients, obviously they're going to have a good understanding of what Oatmeal Health does, because I would imagine they're going to be the first line of conversation about Oatmeal Health, what it does, and about that screening capacity. So have you been able to work with the individuals inside the FQHCs to train them, to develop them? And how is their response in terms of, this is adding a lot to my plate, or this is something that we're really seeing as a value?
So we're going to flip that around. For our two most forward-leaning pilots, we are going to hire someone and put them in the clinic who's pre-trained. And so they're going to credential them for their local zip code and their state, and then we're going to do it internally. And so this is good for a lot of reasons. One, we become part of that team as we want to be for every community. But two, stickiness helps us too from a business standpoint. And so it's great for patients and great for our business.
Got it. Makes sense.
Thanks, David. Next up, we have Erica Frankel.
Thanks so much, Dr. Vachon. This is fascinating to me, and I'm wondering, and making me wonder if radiologists are sort of first out of the gate to be replaced by AI. So you're really finding a niche for yourself. I wonder what, if any, impact there's going to be on other cancer screening rates, or your ability to expand beyond lung, given those numbers you just showed about their ability to report on it. And then actually what you were just responded to made me curious about what happens. Is it scalable for you to hire somebody and put them in a clinic? So I know there's two there. So if there's only time for one, feel free, but I'd love an answer to both of those.
No problem. I'm going to go in reverse order. So we're actually running the numbers with our investor in diligence of how many patients in a clinic need to support the type of service that we have. and looking at the UDS metrics, that the top 700 clinics can support it. And so the unit economics work just fine to do everything we said. And we have it down by how many minutes per call and how to do all the different parts of it. So that was a really specific question that we got recently, and we walked through it all just this week. And the unit economics not only support it, but is nice on the business side too. So we're helping a lot of patients, and this is a good business decision. So that's number one.
Your colleague looks like they answered in the chat here. Breast, colorectal, et cetera, is a plan in the future.
Right, and that was what I was going to say is when we pitch this to the clinics and they start to say, "Wait a minute, why won't you help us with other things?" And we say, "Well, we'd be happy to." And so this adds to our stickiness. And one other thing, so the medical people on the call will know that the newest breast cancer screening guidelines say a woman with a greater than 20% lifetime risk is supposed to get an MRI in addition to their mammogram. But again, this is tricky to navigate. Like, okay, how do you do your Gale risk assessment score? And so anything that's kind of tricky, put on the oatmeal plate, we'll take care of it. And if it's literally, we can't get, people in for a colonoscopy, well, let's do it. And so we're starting with lung because of the new regulatory pressure from USPSTF and NCQA. And we feel like this will give us great tailwinds to then help all the other ones. So totally appreciate it. And we get that question all the time.
Thank you so much for your questions, judges.